Good afternoon, everyone, and a very warm welcome to this webinar in which we shall be discussing the NHS's use of data during the pandemic. My name is Nicholas Carding. I'm a senior correspondent at HSJ and your chair for today's event, which is being held in association with PA Consulting. As you will all know, the use of NHS data has been credited with several game-changing breakthroughs in our battle against COVID-19, from helping identify the impact of dexamethasone in patient treatment to enabling the swift identification of people who needed to be shielded. Data has clearly played a critical role in the national effort to manage coronavirus. But as we battle our way through the second wave, clearly there is much more that needs to be done. So today we are going to be looking at how data has helped the NHS to respond to the crisis, what best practice should be retained for the future, lessons learned from the last 9 months, and what organisations should do to ensure they can make the best use of data in the coming years. I'm delighted to be joined by a really excellent panel of 3 people today, all of whom will bring a very different but extremely informed perspective. Joining me on the panel are Ming Tang, the National Director for Data and Analysis at NHS England and Improvement, James Sumner, Chief Executive of Mid Cheshire Hospitals Foundation Trust, and Jenny Lewis, a healthcare expert from PA Consulting. Now, just before I come to the panelists, I just want to stress to viewers that you are very welcome to submit questions to the panelists throughout this webinar, and we will do our best to get as many of them answered as possible. There should be instructions on how to submit your questions on your screens, and I would encourage you to ask anything you like, given the wealth of experience that we have on this panel. And just finally, if you do experience any buffering or problems with the stream, then click on the Test My Connection button, and hopefully that will help you be able to optimize the connection. So the format of the webinar, I will ask a few questions of our panelists to kick us off, but do send in your questions and keep them coming, and then we'll move into a discussion and Q&A. So I would like to start with Ming. Ming, as National Director for Data and Analytics during a global pandemic, I can only imagine how intense the last 9 months have been for you and the team. Could you just talk us through what it's been like, perhaps first of all, and tell us what your work has focused on since sort of February, March?
Thanks, Nicholas. Certainly has. It's been manic, but very rewarding in some respects, and we've made a huge amount of progress in the last few months than we would have done in years in terms of what have we been focusing on. The data cell team have really been focusing on bringing together all the data available around around COVID, SITREP data, ICNOT data, even GP data now for planning and research purposes, and really pulling together all that information so that we can actually inform decision making, providing a operational layer on top of that, so some analysis, some useful tools around decision making, and then some modelling to understand where the capacity requirements are, forecast where the emissions are going to be, but also just manage supply of materials, products, PPE and all those things across the system. So really working across all arm's length bodies, a really cohesive approach across health and care, and very much really trying to manage and support the systems in delivering what they need to do.
Thanks, Ming. And I suppose one of the more kind of prominent things that certainly we're aware of that you've been doing is obviously the COVID-19 data store, which is something which the NHS has sort of not really had before, I think, to this level. Would you be able to just talk us through a bit about, how you managed to create that and what you've learned from that so far?
Yeah, so very early on, NHS England and Improvement, together with NHSX, worked very hard with Secretary of State and his the ministerial team, to implement the COPI regulations, which really gave us a permissive framework for data sharing. And from that, what we said was, okay, why don't we collect information once and then share it out so that we all had the same information coming through. We were very clear about the security of that information and enable sharing between national bodies and local systems, between health and care, and across trusts as well as CCGs, etc. So that was very much what we did. We set it up against those COPI regulations, working together with NHS Digital to make data available, but also seeking out data for research and also to inform some of those clinical trials and the studies that we've done on diabetes, for instance. So set that up with a very permissive framework, but also a very secure and tidy framework. And it's something that we would like to continue, and we're now working with NHSX to see what the ongoing data sharing requirements will be, so that there is a legacy of that information as well as ongoing data sharing once we come out of COVID.
Okay, yeah, that's interesting, because I think at the start of that process, I remember Matthew Gould saying that once the COVID was over, whatever that looks like, the data store would be sort of disbanded and no longer used. But there is definitely going to be some form of data store going forward then, because it's been so successful.
We have to make sure that we've got the right permissions and the right use cases for that ongoing data. I think that COVID's going to be with us for a long time. We're going to need to understand the impact of COVID on utilisation of services, our treatment for patients, as well as other things. So very much looking to extend the use of that information within the right information governance and the right rules. And that's what the NHSX team are trying to help us do now.
Okay, thanks very much, Ming, and we'll come back to some of the other themes you mentioned as well in your opening remarks. But I'll turn to James as the chief exec of a trust, and perhaps James, before we talk about data, maybe I could just ask you quickly, given all we're hearing at the moment about the second wave, and there are lots of numbers and statistics being thrown around. Maybe could you just tell us a bit about what the impact of COVID-19 is currently at your trust in terms of COVID patient numbers, and if there's any impact on non-COVID care at the moment?
Yeah, sure. So, I mean, I have two roles here slightly, in that obviously chief executive at Mid Cheshire, but I'm also the, as of Wave 2, effectively the Gold Command chair for Cheshire and Merseyside. So I've got a bit of a different view based on my own trust to the others. Over in Cheshire, we have had the impact of Wave 2 more recently in the last couple of weeks. If you look at, obviously, well reported, Liverpool, North Mersey, Mid Mersey, other parts of the patch really got hit hard 6-8 weeks ago. We're starting to see across the system, Cheshire and Merseyside now, a flattening of admissions, a flattening of patients in beds. The death indicator obviously is a slight lagging indicator, but you can see the pressure starting to flatten out. Unfortunately, it's flattened out at a very high level for those in Merseyside. In my own trust, we saw our numbers doubling over the last few weeks. Again, we're starting to see a bit of a flattening out now. Speaking for my own trust, the numbers aren't as high as they were in Wave 1, around about 50%, but I know I've got colleagues across the system who've exceeded the in-hospital patient numbers of Wave 1. So a bit of a different picture, even though it's quite a big geography, Cheshire and Merseyside, in a relatively small part of the UK, quite different pictures.
Yeah, and obviously we read about the impact on non-COVID care, and particularly in elective care in Merseyside. What's the situation like in Cheshire, just in terms of the trust there? Has it had much of an impact on the sort of elective and other non-COVID work there?
I think we've not had as much of an impact on the elective in the Cheshire side in terms of COVID, specifically, meaning we've had to cancel operations to create bed space, although that's relatively small numbers. What we've got, which is what the whole country's got, is the challenge of providing COVID secure environments in quite often outdated hospital environments. So in terms of recovery, we're managing to do sort of 70-80% in a good period of what we used to be able to do within the same infrastructure, which is a fairly similar figure nationally. So the worry is, of course, that we've still not managed to catch up with where we used to be when we're fairly COVID secure. When you get then a second wave that's impacting as well on parts of the system, that can significantly impact that even further. But I've been impressed, I have to say, with the system in both Cheshire, Mersey and the North West with the wave 2 hit that it's had. The numbers of patients still being treated, while we see the reported challenges, is still pretty high. We're still getting through 60-70% of patients in a lot of those areas.
Okay, thanks. Yeah, and I suppose we're going back to the theme of this webinar then, so that the data, perhaps you could talk a bit about how your trust has used data in response to the pandemic, and perhaps talk a bit about what you think were sort of the biggest game changers for both your trust and the STP, perhaps more widely.
Yeah, sure. So probably a little bit of both, really. So in terms of my own trust, I mean, if I reflect on the sort of positives of this, I think it's really driven a thirst for intelligence and particularly joined up systems thinking in a way that probably we all aspired to, but maybe didn't necessarily have the same burning platform to achieve as quickly, or didn't have the time. It has really driven that, and I think I've started to see both within my local place and as well as across the SDP. In a way that we've not seen before, people starting to use data on prevalence and testing and population rates and informing decisions about what they're going to do in a hospital based on what might be coming down the line in 2, 3 or 4 weeks. And I think the criticism, perceived criticism when you're in the hospital sector is hospitals usually wait until they're hit by something to be then prepared to do something about it, particularly winter pressures and other things. But we're really starting to see a shift in the system about, well, actually, there's decent predictors here of when pressure is going to hit us, which I don't think we'd seen before. We really have done some good stuff across the STP level early on, and driven by COVID and mutual aid requirements, but also around the sort of phase 3 restoration of elective activity. So we set out early on in the STP footprint to say, well, what we really need is an STP-wide system model, so we can start to look at individual organisations and using that sort of modelling capability, understand the pressure on those organisations individually at a point in time and also as a collective. And that was really important for things like mutual aid around things like PPE. Going into phase 3 planning, really important, because we knew there would be inequalities in the system by virtue of the fact that, just as an example, hospitals that had cold elective sites would be able to plan better for recovery of elective activity in a COVID secure manner than hospitals that were all on one site. So the modelling really helped us understand, site by site, what we think might happen going forward. And we're in a position now where we've got that sort of rolled out within the STP, and a really good sort of piece of work to help us plan. I think the real challenges for us in my own organisation I'll talk about, but I suspect it's similar elsewhere, is the lack of high quality workforce data. So we've got really good information across systems about activity and what's happening, but I think what this has really shown is probably the lack of high quality workforce data. And when we had to get into detail of, in the previous wave, who is needing to shield, who are we risk assessing, who are we testing, that was all quite a challenge, and we had to invent a lot of workarounds and new systems to capture that. We have just come off an exec meeting today about how we're going to manage immunisation, and the same sort of things apply there, how we're going to record and contain all of that, and make sure that our records are good in terms of managing our workforce. And sickness absence has been a really difficult one as well, around what's COVID absence, what's not. Our counting and recording systems, just weren't set up in a way that allowed us to do that very easily. So that's been a real challenge. But out of all of that has come some really good innovation, as Ming said earlier, about things that we never would have done. So, for example, a single cancer PTL across the STP. We've got to sort this out. Let's get all the cancer patients onto one single PTL across the system, and let's treat them in priority order. And from a sort of inequality of access perspective, that's incredible. I don't think we'd have got there without something like this forcing our hand in some ways. So a lot of silver linings to the sort of dark clouds that we've had.
Okay, thanks very much, James, and we'll come back to some of the things you talked about there. So certainly the workforce data is interesting, but I just want to come to Jenny as well. So Jenny, you obviously come at this from a slightly different angle over in the private sector, but could you perhaps give us your reflections on how the NHS has used data so far, and if you're aware of any sort of areas or organisations that perhaps managed to extract the benefits of data particularly well, if there are any sort of areas of practice you'd like to talk about, or just give us your thoughts on how it's been so far from your end.
Sure, yeah, thanks, Nick. I mean, just so people understand a bit about me, I've worked in healthcare analytics for years now. So, you know, very much reflecting on what others have said. If we look back over the last 10 years, that we have talked so much about how can we get organisations to start sharing their data, how can we get individual organisations to surface their data, how can we help Ming and her teams to be able to get access to the sort of data that they need to make sensible decisions nationally, and then filter those information down through the various layers of the NHS. So it's been such a topic of conversation, and there's been all these blockers that people put in the way. We can't do it because of technology, and we can't do it because of interoperability, and we can't do it because of information governance issues. And the progress we've made this year has been absolutely fantastic, and I think we have to be really celebrate the successes that have come out of this, and all the good work that's happened at all layers of the NHS. So I mean, we've been supporting Ming with some of the great programs that have been happening centrally, the work that we've been doing with James to get all of the organisations across the entire of Cheshire and Merseyside to agree to sharing their data with each other, and also working with individual hospitals who every single hospital in the NHS had to suddenly remodel all of their activity overnight, only a few months ago, and we've seen all that happen. So it's been incredible. I think the thing we've now really got to start to work out is what were the drivers of those, and how do we bottle that and make sure that we don't lose it moving forwards. And certainly one of my reflections on that is how much it's down to trust between organisations, individuals, and up and down through the system. So certainly, I think the Cheshire and Merseyside story is particularly good for that, whereby we really did work very hard with all of the individual trusts to help them to understand the benefits that they were going to get from sharing that information, and have actually now established a platform which will allow that information to persist and keep flowing around the system as we continue through this period, but hopefully way beyond that. I don't think any of that could have happened without that trust having been there in the first place. And as we move to the more exciting things like joined up PTLs across regions, and some of the sort of predictive analytics that James is talking about, if we can get people to really trust in that information and understand the value that it can bring to their organisations and how they're running them, then there's huge potential that we really could see this growing into the next few years, which is certainly what I would hope happens.
Absolutely, yeah. Thanks very much, Jenny. I can see just from the questions, we've already had 2 questions come in, so we'll come to those in a moment. And just another message to the viewers to please keep sending in your questions. But I just wanted to pick up on that point that James mentioned in terms of the workforce data, because clearly I think it's very interesting to kind of hear what needs to happen next now, and what issues need to be solved going forwards. I just wondered, James, could you just set out a bit more what exactly the issue is in terms of the workforce data, getting the data? What kind of data are you talking about? What you need it to show? And have you got any thoughts on how you're sort of planning to work on that going forwards? And then I'll perhaps come to Ming after that for her take as well.
Yeah, I mean, Ming will have a better view of this across the board. I mean, I'm speaking about my individual trust, but if I talk about the last 4 or 5 trusts I've worked in, we've always been in a similar situation. And I remember in a trust I was working in that was in a turnaround situation, and we had private sector colleagues come in to try and help, and they couldn't fathom that organisations with 5, 6, 7, 8, 9, 10,000 people in them couldn't tell you how many people were in work today, couldn't tell you how many people were actually off with a specific reason. And we do have some sort of very antiquated systems around staff absence and recording. The staff sort of electronic record systems are used to varying degrees, I think, in different organisations, and not necessarily connected in a way that they are useful from a business intelligence perspective. In some organisations, I'm sure there's others doing it really well. So I know it's something that we've talked about here. Again, I think this probably shines a light on where we have learned through this process, rather than our organisation saying, what are we going to do about that? We're having a Cheshire and Merseyside conversation about what can we do about that, which is great. But Ming may have sort of a different view around what path that needs to take going forward.
Yes, so I think it's a really difficult one, isn't it? We have got antiquated systems. Those systems have been implemented to varying degrees, varying standards. We don't really have a consistent way of logging roles, what someone's doing. So we might have really good data on banding, but we don't have very good data on what roles people actually play. And people change roles so frequently, and our systems are always out of date. On top of that, for COVID, what we've really wanted to do, looking at inequalities and targeting, is the demographic data of our staff, and that wasn't really collected very well. And that's something that we need to kind of pick up and make better, and then make that data back available to individual trusts that are actually using that information, and at the national level. So there is some work in both creating the right data models, standards, and also making sure we capture all the information in order to do modelling. So when we did the people plan, it was largely based on interviews rather than a really big data analytics support. I mean, there was lots of analysis in there, but in order to project out, availability for beds and staffing, we spend a lot of time, because we can count beds, but counting the staff in order to manage that. And as we move towards multidisciplinary teams, actually understanding the new workforce models and planning that in, and things like digital that's happened, digital in appointments in both secondary care as well as in primary care, that uses a different workforce model. So all of those things creates more demand for workforce information against the backdrop of quite antiquated systems. So there's quite a bit of catching up to do. But I think, James is right. The desire's there. People want to do this because they want to get it right. And that will put us in a much stronger position going forward.
I just wonder, in terms of driving that whole agenda forward, do you think there'll be, is it necessary to change legislation around IG to achieve that? Do you think, both James and Jenny and Ming for that matter? I just wonder, because obviously we've got the COPE notices in place, which you mentioned, but when they eventually expire, how easy / hard will it be to deliver the changes you'll talk about without some kind of new, rules in place, whether it's legislation or otherwise? Just wonder if I get the panel's thoughts from all three of you, perhaps, on that question. Starting with, we'll start with Ming, if that's all right.
Yeah, the data policy team in NHSX are doing a cross-system data strategy, in which part of data sharing will be a big component of that, and then really understanding what the legal basis will be in order to enable sharing with and without legislation. So we're doing both options. It comes back to Jenny's point earlier on around trust. When systems actually trust each other and they're willing, to put their data controllership hat in the ring so that the system can actually share across that, it is possible. It's clunky, but it is possible without legislation. Some legislation information would make it a lot smoother and a lot easier, because really what we're looking at is joining up all different bodies, is mandates, in order to create a mandate for the system. So it is possible, and lots of systems like Cheshire and Merseyside have done it. So it's really making sure, if you've got trust in the system and people are collaborating and willing to do the hard yards. It's clunky because individual organisations has to have individual data sharing agreements. The other bit is we're working with Dame Fiona to really start that conversation again with the public. We need to make it clearer to the public why we need this information and why data sharing is actually so important. So it is possible, just, it would make it easier with some legislation.
Just to add, I was going to say, just to add to that, I think one of the things that we could and should all be doing within the NHS is collecting the stories of where it's gone well and why it's gone well and what benefits have come out the back of it. That will support in a whole range of ways, not least any new legislation that we did want to push through, but all of the good work that Fiona Coldscott's doing around trying to explain to the public why there are benefits of this has been held back massively because we haven't been able to describe it. It's a difficult thing to describe, and we're really collecting those stories now, I think, of where true benefits have been seen, and I think it's on all of us to make sure that people are aware of that and use those stories to encourage other areas to do it. As Asming said, there's nothing really stopping us from doing it at the moment, apart from people's willingness and drive to make it happen.
Thank you, Jenny. James, do you have any further thoughts on this as well? And I don't know if you've got any sort of thoughts on reflections on how you've done it in Chester Remote side and what kind of the enabling functions were to be able to get that sharing that you managed to do, what the main factors were?
I think, I mean, as I said earlier, having a burning platform where we've all got a significant challenge is always helpful, isn't it? And that has helped to a degree. We've been able to sort of push things through in terms of data sharing agreements that, as Ming said, traditionally might have been on a long list of things to do that weren't seen to be as important. So that's undoubtedly helped. I think the other thing is starting to, I mean, I don't want to rehearse the ground that Jenny's been over, but starting to put something in place that's useful to people that they can see a benefit from really does drive that. So the sort of joint modelling that we've been doing and are still driving through the system here is, at a point in time, and we're there now, where we can sit in a room, as a collection of chief executives or medical directors or whatever, and have a look at, that is how our system is performing together, and that's how these are the areas we need to help each other. Really reinforces that message, and even up to a few weeks ago, we've still been trying to do that with slightly wonky SITREP data and people trying to correct it in the meeting, and having that sort of shared view is really important, and that shared case study. So I think we're getting there now, and I'm sure other places around the country are in exactly the same place.
I think galvanising around the agenda. Sorry, Nicholas, I was just going to come in and say galvanising around the agenda, the place-based commissioning and working is going to make it a lot easier. And I think that's kind of what we need to kind of bottle up and make sure we continue post-COVID or as we go forward.
Thanks, Ming. See, we're getting questions, so I think I'm just going to start running through some of these because we are very keen to make sure that your questions are answered, and do please keep them coming. So I think the first one will be perhaps best answered by Ming. Someone says, great relief to hear that COVID data collected won't be wasted. This is about, I think, the COVID data store. Will it be possible to share that data between local places and nationally, both across health, across all systems, including across both health and social care as well? Ming, what are your thoughts there?
Very much the mission of the data store was to share data between national and local teams, collect once and use many times. So that's been the kind of mantra of the data store, and that's kind of why in the front door process we actually had all the arm's length bodies together to do the triage, and hopefully people are actually seeing the benefit of that.
Okay, thank you. And we've had another question on systems, which I think we have mentioned earlier, but we'll go through it. Could you please talk about how well prepared the NHS was or is in terms of data platform bracket systems to be able to store, manage and share data following information principles and data governance policies? I mean, maybe James, do you want to just kick us off with that one and talk about the systems you've got in place in your patch, perhaps first of all?
Yeah, I'm no expert, I have to admit, on this particular topic, but in terms of the systems, I think certainly in Cheshire Merseyside, there was already pieces of work, largely because of the integrated care agenda, I have to say, and I think it's the same in other areas I've worked in, where everybody wanted this to happen and everybody wanted to find a route through it there was obviously usually, one or two or three or four different ways that it could be approached, and that often was the blockage in terms of time. So as I said earlier, I think that the sort of burning platform of needing to move quickly on this enabled us to take some decisions really, really quickly that potentially previously would have perhaps taken a long time, because we could see the rationale staring us in the face. So I don't think it's necessarily that places, but again, I can't speak for all of them across the country, are wanting to go in this direction. It's often been around, how are we going to do it, which product, platform, whatever are we going to use. That seems to be the factor that slows it down. But again, Jenny or Ming may be better placed than I am to take a sort of wider view on that.
Yeah, Jenny, do you just want to come in on that point as well?
Yeah, I mean, I think the answer is it's very variable. There's no real standard approach, I think, at the moment across the NHS to these things. All that said, on the whole, the system was probably relatively, and still is relatively, immature in its use to sharing storage of data for some of the reasons we've already mentioned, including particularly information governance, but also lack of understanding of the benefits and the investment cases that would follow a better articulation of those things. So yeah, I mean, highly variable. There are some great stories about systems which have been sharing data for a while and have been particularly able, for example, to use some of their linked data sets to understand some of the growth in the unmet need that's developed as a result of COVID, where there was a significant period of time where we know that patients weren't accessing the healthcare services that they needed, and where you've got those linked data sets already there, then you can start to really understand that, and those local areas are able to then actively target the members of those populations that particularly need support. So there's some great stories of how previous investment, I think, has been incredibly valuable this year, and again, hopefully that will be very useful in helping other areas to catch up as we move forward.
Yeah.
Thanks, Jenny. Yeah, and of course, Matthew, sort of, go on.
I was just going to say, I would agree with Jenny. I mean, there's some really great case studies, like in Frimley, where they already had done quite a lot of work and they were able to expand, but also because they already had almost a blueprint of what was necessary, they were able to expand across their patch as well, so further out, growing from Frimley out. Similarly, in Greater Manchester, they've grown and worked very closely with public health, so therefore their modelling techniques has really helped them improve and target. So this learning, I guess, that we need to take back in the system is that the integrated care record and linking those data sets is a fundamental building block for being an integrated care system. And that's kind of, without that, you can't really move on, you can't move past go. So sorting out those data sharing issues and information governance and agreement and trust of a system is really necessary. So I think that this experience will accelerate that work. And we're hoping that going forward in 21-22, that we're able to accelerate integrated care much quicker.
Just on that point, Ming, obviously I think it was NHSX have set STPs and ITSs the target to have some kind of shared care record in place by, I think, September next year. Do you think, is that going to drive a focus on making all those different systems that are currently in place more interoperable, or getting all trusts to be more consistent in the systems that they are using so that interoperability is less of an issue? Which one is sort of the more likely to happen, do you think?
A bit of both. Where it makes sense, it'll be making trust systems more consistent because they're coming together and it makes sense. And particularly if they've got to invest in an EHR, they'll probably buy the consistent EHR. So that would be one side. Where they haven't, it is possible to be more interoperable, and we will build on being more interoperable. We're a federated system as a healthcare, and it's not going to be one size fits all. But between national and local, what we're really trying to do is that that interoperable piece and making sure that we've got consistent data models to allow us to flow information up and down.
Okay, thank you very much, Ming. We'll have some more questions, so I'm just going to keep going through them, and do please keep them coming. We've got about 10 minutes left. Someone is asking, how can we get more leadership focus on getting the basics right? For example, are there any acute organizations that have cracked an accurate digital count of beds that has completely replaced a manual count? Ming, perhaps best if you start with that one. What are your thoughts on that, on getting the basics right?
I'm laughing because I've just been on two calls today on definitions of beds. I never thought before I joined the NHS I would spend so much time defining beds. It is a movable feast, isn't it? When we came into the first part of the pandemic, we were really, I think trusts were just so eager that we counted everything so that we knew exactly what was available. We're now more refined to say, actually, with the IPC requirements, can we be bit clearer about what's actually available to use, and we don't have a digital solution, I'm afraid. I'm really not even sure, trying to explain to ministers the other day, some of this information that we collect, it's not easy to extract, it's not easy to automate, just because we don't have barcodes on every bed with definitions and classifications, and beds move. By the way, we in ICU, we were counting theatre beds when we needed to, because we actually needed that capacity. So there is a bit about how we're structured, but I don't think, unless we have a wholesale RFID kind of program across the country for all trusts, and I don't think there's the money there at the moment to automate that type of stuff, is actually quite hard and would need significant investment. Unless Jenny's got some ideas that I'm not aware of.
I think one of the things that we found in the work that we've been doing around the Cheshire Mersey modelling is, and this obviously doesn't help at a national level, but the more at a sort of STP, ICS level that you can build that up from the ground, rather than starting with what sort of national SITREP data is required. National SITREP data is very important. We've got to make sure we get it right, clearly. But in a sort of smaller system, at STP level or in a local place, we've been able to start that conversation with, well, actually, let's go and have a conversation with the medical director, chief operating officer, director of nursing about what their hospital looks like, what bed is a bed, and what bed is not a bed, and the same things that sounds like Ming's been talking about as well. But it allowed us almost to build up a picture of an organisation for the purpose in which we wanted to use that data. So what are beds, what are staffable beds, what are not, going to help you with the COVID effort and so on. And if you get that level of engagement in modelling and data systems being built from the ground, again, doesn't help with the national SITREP, but for what you're going to use it locally, I think that's the answer. At the moment, I can say, wholeheartedly trying to do these sort of gold command meetings every day using SITREP data and other returns as the driver is quite challenging, because we end up sitting in a meeting trying to subtract paediatric bed numbers from bed numbers just to try and get to what we think today's position is on critical care. So, the more that we encourage locally that sort of freedom to determine what things look like built from the ground up, while still making sure that we feed the national machine in a correct way, is really important.
Just to quickly add that I totally agree, and the approach that James described that we've taken in Cheshire and Merseyside has been really successful in us being able to describe all those organisations. I do think, though, that there is a bit of an onus on those of us who work as health information professionals to think about this, because we are very, very, very good at analysing the demand side of the NHS, and we've spent years working up the data sets to do that, and we can get into great detail of how we describe activity, and we really have almost nothing that describes the capacity side of things. And it links back to the discussion we're having about workforce. We can't describe the size of the service that we're working within, and we trivialize the problem. We think it's just like counting nurses or counting beds, and actually it's not. It's quite complicated, and you either have to take a very bottom up approach very bespoke to each organisation to get it to work, or you have to accept that it's a very manual process at the moment, and that there does have to be a better answer, but it is going to require a bit of a concerted effort from people to think about how do we want to describe our available resources, and then how do we get that information to flow in such a way that people can do something sensible with it, because there's almost nothing there at the moment, I think, that helps us.
Yeah, okay. And I agree, and I think that requires some maturity about consistency of units and definitions, and that's been the difficulty, because that's quite bespoke at the moment.
Yeah, I think another person is asking sort of a slightly similar question, but phrased in a different way. It's quite a short one. Please, could we have an agreed NHS analytics maturity model to measure our progress against? I presume that is one question. One problem as well for trust at the moment is simply there's so much variation that it's very difficult to know where you are, given all the variety out there. Ming, I don't know if you want to just pick up that point.
I think there are many. Yes, I agree. We should have one, but it's so difficult to get everyone to coalesce around one nationally, because we are very different. That we are pulling together Health Education England, ACFA, and also all the national teams to see if we can pull this off together. But it's almost like we also need support from the systems to actually help us coalesce into one framework, because everyone does things slightly differently. And as I said earlier on, we're federated, we're not top down, centralised. So it makes some of those things really difficult. But I'd love there to be just one, but it's just really difficult to get that agreed. And by the time we've agreed it, everything's moved on.
Is when I listened to Matthew Gold speak recently, he several times mentions this piece of work going on at the moment called What Good Looks Like. Is that going to be possibly the closest that will come to some kind of sort of standardized national vision for what trust should be doing?
Yeah, so there's quite a lot of input into Sonia's work and what good looks like in both the digital side as well as the data side, as well as what the capability looks like. Again, that's what I meant, we are having a crack at it. Hopefully people will coalesce around that, but definitely the ambition's there.
Okay, thank you very much, Ming. I'll just take one more question, perhaps, from
Nicholas.
Another viewer. Sorry, James, you want to come in?
This is probably against protocol, but I'm going to try and suggest that I'd really like to discuss the Mark's question that I can see here about the most valuable non-health data, if that's possible. Would that be all right?
We have got time, yeah. So just for the benefit of the viewers, the question is, what does the panel think about the most valuable non-health data that we need, and how can we use it? So James, do you want to kick us off with that one?
Good question. Yes, I'd love to. It was just for me, I've experienced this so many times now about we do a great job of collecting health data and health information and then trying to connect it. And I'd really love to hear some great examples of how we have collected data on what patients want rather than what we think they need. And, I tell a story which I won't go into at length now whenever I have a conversation about integrated care, about a lady I visited in some flats who was in a wheelchair with a leg ulcer, having IV therapy teams, the local community nurses who I got out with coming dressing every day, repeated appointments trying to save a leg. That actually, when I asked her what she wanted, she wanted to have the leg amputated so she could get back out again, because she'd been consigned to a temporary wheelchair in a house for 9 months with no hope of getting a ramp put in by the council because it was temporary. So, this sort of whole thing of the social isolation of people, and sometimes our efforts as a health service to try and do everything we possibly might be able to, rather than really understanding what they want. And I'd love to see sort of integrated share care records that operate across agencies that talk about the individual as a person and what they want, rather than just a list of conditions, a list of medications, and a list of referrals. And I'd love to hear if anyone's managed to crack any of that.
Yeah, perhaps just Ming and Jenny would like to address that as well quickly. I see we've only got about 2 minutes left, but can I just get your thoughts following on from James's point there, starting perhaps with Ming?
Thanks, Nicholas. I totally agree. I think we need to move the nexus away from services or conditions to people, and people in the widest sense. Yeah, and I think that's why the place-based piece is really important, James, because that's our opportunity to really start looking at the local conditions and understanding the context that people live in. I don't believe that we will sort out health inequalities and population health unless we can do that. Don't think there are many areas that have done it fantastically well, because we're still too scared to share data outside of health. And I think that's part of the discussion around data sharing, is how do we get the public trust into adding these additional pieces of information? Because, you know, from one lens, it does look quite intrusive, but from another lens, if we are to do the services design the services in a way that actually helps people. So I think it's a great idea, James, to get people's, what they want, because that will then expose the type of data that we need to bring together in order to answer that question.
Jenny, I'll let you have the last word if there's anything you'd like to add on that sort of interesting point there. Take us away if you've got anything you'd like to add for the last few minutes.
Well, I certainly think that really brings us back around to where we started the conversation, which is this has been a year of so much of change and acceleration in our thinking about the use of data and all the benefits that it can bring us. The glorious future of that is a fully linked data set across working across health, social care, education information, really starting to understand that richness of information about people so we can design services for them. So that's hopefully where we're going to get to, and this year has, fingers crossed, given us a big leap forward in that agenda.
Okay, well, it's always nice to end on an optimistic note. So thanks very much, Jenny, and thanks also to the rest of the panelists, James and Ming. We are about out of time, so thank you very much for viewing this webinar. We're very grateful to PA Consulting for sponsoring this session. I hope you found it interesting, and do stay safe, and thank you very much for watching. Goodbye.